Again, my name is Wendy Waldman. I am the HRSA grant coordinator at RHI. I'm a certified brain injury specialist, and I've worked with brain injury for about 9 years. Currently just moved to Indiana, so I'm very happy to be here. Our webinar is on driving after brain injury. Basically, we're going to be reviewing the overview and importance of driving, research and statistics, how brain injury can affect driving ability, how to determine if one is able to drive safely after brain injury, general information on a driving evaluation, legal and insurance information, other transportation options, and then we're going to present a case study. Obviously, the whole time of this webinar, we want to keep in mind that every brain injury is unique and not everyone will fit into what we're speaking about. First, obviously, we're going to talk about the importance of driving. The importance of driving. Driving is basically your independence, and you hear that from people all the time when you're working with them on brain injury. The first thing I hear very commonly from people is, when can I start driving again? Because that is your independence. It's also part of your community reintegration. It's part of getting back into the community, going to places where your friends are, going to work, going to school, going to family functions, and so on, going to the grocery every day. It's also a method of control. When you are driving, you are in control of the car, and that's something that everyone wants. One thing I put at the bottom of this is that driving is a privilege, not a right. And that's something I'm sure we've all said at one point of our lives. I wanted to talk to you a little bit about the overview of driving after brain injury. People who have sustained a brain injury often find that their driving skills are no longer the same. Obviously, brain injury can have cognitive effects, it can have behavioral effects, it can have physical effects, and all of those combined, or just a little bit of each, can make driving quite different after you've had any kind of brain injury. Family, friends, and caregivers may also be worried about brain injury, about whether a person can drive safely. Obviously, if they're probably even more so if their brain injury came from a car accident or a motorcycle accident. But I think everyone will worry about their loved one driving safely after a brain injury. And the person with the brain injury is oftentimes worried about driving again. They may be very scared to get back on the road. They may be, scared around other drivers. They may only want to drive at certain times of the day and things like that. So that's basically our overview here. Research and statistics, it shows between 40 to 60% of people with moderate to severe brain injuries return to driving after brain injury. And like I just discussed, people with brain injury may place limitations on their driving habits. I know that there's a lot of people that may not like to drive at night or get on the highway. They may only take side roads. They may only be willing to drive, when they're feeling okay. People may place some limitations. When you have a brain injury, sometimes you may have a lack of awareness into your deficits. You may have a lack of awareness into what you're still able to do without support or with support. And if you're not able to recognize that, obviously that's an increased risk for the person driving and for everyone around. People also can experience difficulties with visual stimuli, which can affect their driving performance when it comes to seeing the big picture, seeing in their peripheral vision, and just straight-on vision. How can brain injury affect driving ability? Well, we kind of just started talking about that. Obviously, brain injury is the ultimate multitasking experience. I picked a funny picture, but literally this is true. We've all looked over. Some of us may have done this themselves, but we've all looked next door to us, and the person next to us is putting on their makeup, talking on the phone, reading the paper, typing a text message, making their coffee, eating their food, scolding the person in the back seat. So it's a multitasking experience. You have to be able to pay attention to several things at once, which we know is difficult for everyone, let alone have a brain injury on top of that. Brain injury can affect the many physical, cognitive, and behavioral skills needed to drive well. So first we wanted to talk about those physical skills. Reduced strength and coordination. A lot of times people with brain injury may have tremors, they may be weaker on one side. Coordination is certainly multitasking, so that may be an issue. Hearing loss, your hearing can be affected after brain injury, or you may have tinnitus, which is a ringing or buzzing in the ears. Headaches are very common after brain injury, and when you have a bad headache or a headache, you may not feel well, and that could affect your driving performance. And obviously fatigue. People with brain injury can, especially initially, can be very fatigued very easily, and you never want to drive while you're sleepy. And if you even have a lack of awareness about that, that could be a double whammy there. Vision. Vision can be very affected by brain injury depending on where in your brain your injury occurred. This is not just clarity that can be provided by contacts or glasses. You give someone contacts or glasses and then their vision is okay and they're able to drive. They must be able to concentrate attention in their central vision. They must also possess good peripheral vision, being able to see things out of the corner of their eye. And that's something that is often affected after brain injury. The last VR webinar we did was on vision and brain injury, so I'm sure you have better education about that now. Also perceiving spatial relationships, positioning your vehicle in a lane with traffic, other cars. Picturing the vehicle allows judgment of distances for all purposes. Even yesterday when I was driving to work, I had a guy on my tail, and as you know, the roads aren't extremely clean everywhere, so I didn't understand why he was riding the back of my car when anything can happen. So put a brain injury on top of that with a vision problem, then we've got a real problem. Seizures. Indiana law states that there's no set seizure-free period in order to be able to drive. People with brain injury will oftentimes have seizures after having a brain injury. Not always, but often. The Indiana law states that anyone who is actively having seizures, there's no law that states you have to be 6 months seizure-free or a year seizure-free. They don't always revoke your license after you have a brain injury. They don't always revoke your license if they know you're having seizures. But it basically says that if you cannot be denied a license if you present a statement from your physician stating that you're under medication, your seizures are being controlled, and you're seizure-free. A person whose license is revoked for other medical reasons is distinguished in the records from those that are just suspended for driving violations. Brain injury can also affect the many physical, cognitive, and behavioral skills needed to drive well. So now we're talking about the cognitive skills. Reaction time. Obviously, when you are driving, you need to be able to react. You need to be able to react quickly, not just for your own driving, but to the other cars, people that can walk out in front of you, animals. You have to be able to present good judgment, which we know can be very affected by brain injury. You have to be able to concentrate. It's very difficult to maintain focus and concentrate after having a brain injury. And in order to drive, you have to be able to concentrate. Multitasking, we discussed. Memory, which I think probably most people know is a huge, very common deficit with short-term after brain injury. And if you're driving and you forget where you're going or you forget which direction you're going into, that can certainly throw you off. And confusion, being able to not remember where you are or getting confused about, which one's the gas pedal and which one's the brake pedal. I mean, all kinds of things can happen with your cognitive skills. And then there's behavioral. We know that some people with brain injury may have some sort of behavior deficits. And not only just brain injury, but road rage is actually quite common now in the world. When you have a brain injury, I'm sure that's more exacerbated. A lot of risky driving behaviors. And, even not having a brain injury, you can't just scream at anyone on the road. You can't use hand signals and things like that because you don't know how they're going to react. So how do you determine if the individual is able to drive safely after their brain injury? Well, I'm going to go ahead and hand this over to my supervisor, Laura Trexler, to continue.
Thank you, Wendy. Oh, squeaky chair. Sorry, folks. This next portion I need to give Wendy credit for. She actually put the slides together, and I may need her assistance in some components of this information. She was the one who did a great deal of the research, so thank you, Wendy, for doing that. Well, I suspect that most of you have had access to rehabilitation providers who play a role in helping make the determination about whether or not someone is ready for driving. You'll often hear therapists provide information based on what they've learned about the individual in the clinic. Sometimes the doctor will be the one to initiate raising the question about driving skills, or a neuropsychologist. As Wendy has described, there are a variety of things that we need to take into consideration, including, is there a seizure history? What are the current medications, including the over-the-counter? Because sometimes the over-the-counter medications can have side effects that impair driving as well. Some of the conditions, of course, that could be problematic would include blurred vision, dizziness, slowed movement, inability to focus, sometimes nausea. I know that folks probably know that a lot of our people take sleeping medications, and the rate of metabolizing that out of their system may vary. Many of our folks are on anti-seizure meds, which also can be a depressive to the central nervous system and impair driving. So it's really important to take a good look at that and consider whether or not that will be a factor that should be taken into consideration. Of course, the individual plays a role in the statement of whether or not they feel ready to drive, and this is a complicated issue. Some individuals may have very good awareness and may feel very comfortable talking to their team and exploring whether or not it's the right time to embark on a driving evaluation. Others might not be as aware as we'd like them to be, and it becomes a difficult discussion to encourage them to wait the appropriate amount of time in their recovery curve before they embark on the driving evaluation, because of course what we all want is a successful outcome. Another important point is that some individuals may have the cognitive capacity and the physical and the visual capacity to drive, but they may have a great deal of anxiety or fear about returning to driving. If the acquired brain injury was a result of an automobile accident, that can play a role. Also, I think an important point, some individuals experience movement differently after an acquired brain injury. If they have some visual or perceptual system problems, they have trouble judging space and judging speed, and they might feel a fair amount of anxiety imagining that they're going to be in control of a vehicle and trying to manage the changes in their sensory system. So as we had mentioned, sometimes the neuropsychologist, if it's a provider group that has access to neuropsychology, they can play a critical role in offering a neuropsychological evaluation to assess many of the skills that we consider when we think about returning to driving. The cognitive, attention, processing speed, visual spatial skills, etc., as well as the emotional demeanor. And based on the evaluation that the neuropsychologist may make, or any of the members on the team actually, they may say that the individual is appropriate to complete an on-the-road driving evaluation, or they may need to wait for several months and reevaluate whether or not the physical changes are adequate to embark on a driving evaluation, or if the visual system has progressed, or decision-making and problem-solving and reaction time has progressed to a point where they're ready to continue. There are some cases where driving evaluations are actually contraindicated. It depends on the level of severity, but there have been times, as you learned in that statistic that Wendy gave you in the beginning, I believe it was 40 to 60%. So there are times where we have to help individuals understand that it's an important time to retire from from driving for safety reasons. So when we do a driving evaluation, I'm going to be speaking from experience within the RHI system, but actually, as you know, there are a variety of evaluation programs across the state of Indiana, and if anyone has specific questions about those, we do have a list with us that I'm not sure that you have access to yet of the CDRS programs across the state, so we could certainly give some information regarding where you can make referrals. A variety of people can do make a referral for a driving evaluation. In our system, we do require a physician's prescription. That's because we are working, the occupational therapists are the ones within the RHI system who perform the driving evaluations. And by state regulations and national regulations, we need a physician's prescription. Although you could have someone's family member call an organization and say, you know, I understand that my person is receiving therapy with you and physical therapy, but I would like them to have a driving evaluation. If your organization offers that, I want to make a referral. Tell me what I need to do. And then we work collaboratively with the families and walk them through each step of contacting the physician's office and stating what the referral needs to have written on it, or asking them if they would like us to cover that step. We certainly would be happy to do that for them. You'll see at the bottom of your slide that the evaluation and trainings are often offered by professionals who are certified through the Association for Driver Rehabilitation Specialists. You might hear us say ADED. There's actually a pretty exhaustive training program. I'm sorry, I'm going to go back one slide. And when an occupational therapist, for example, or other healthcare professionals complete this program, their credentialing has the CDRS behind their signature, and that's Certified Driver Rehabilitation Specialist. I suspect that many of you have worked with some in our state at Crossroads and probably at RHI. Before we do the assessment, the person must have a prescription, as I stated, and a valid driver's license. And here's where Wendy gets all the creative credit for finding Elvis Presley's picture to put on that license. There are times, and you may have experienced this with some of your clients, that excuse me, a license has expired. Of course, no one ever times when they have an acquired brain injury, and they may land in the hospital and then go through acute and rehabilitation care, and it's 8 weeks later, and by golly, their license has expired. At the Rehabilitation Hospital of Indiana, we work directly with the Bureau of Motor Vehicles, and I think Crossroads does the same, to arrange obtaining a learner's permit for the individual so that they can participate in a driving evaluation. We have some contacts there that we've worked with for years, and it's not that difficult of a process to work them through that step. As I mentioned, it's the Association for Driver Rehabilitation that will credential folks, and if you want to have a list of those professionals, you'll find it on that website. Again, we have a list with us here, a hard copy, so if you need to get some immediate information and you don't have access to that website, let us know. Our organization, and I think Crossroads may do the same, has two components to the driving evaluation. An individual is referred, that we make sure that we know what kind of vehicle they want to return to, what driving goals they have. We check their insurance to make sure that there's coverage for the driving evaluation. We find a little bit out about what their physical skills are like so that we might plan the appropriate physical equipment in the car. We find a little bit about what their visual system is like so that we can have the appropriate equipment available for that. A person will come into the clinic and they'll spend about An hour and a half with an occupational therapist or CDRS. If it's not the CDRS performing the in-clinic portion, they have oversight over what the occupational therapist reports and in the decision making. And the first component of this has to do with, let's just, check the strength and range of motion in the upper extremities. And I need to put you through an eye test screening so that I know that you actually have functional acuity. And I might take a look at what are your visual fields. And when I say visual fields, I'm referring to whether or not they have any new blind spots. Do they have double vision that's going to interfere? How would they answer judgment and reasoning questions related to emergency traffic situations? What do they know about the Bureau of Motor Vehicles' current laws? We give them a quiz and then talk through the answers with them. If they have any difficulties, we quiz them on the signs. So it's fairly comprehensive, but it's primarily seen as a screening to get some information about what might we experience when we're behind the wheel and what is the best way to cue that patient to help them improve in their physical performance and judgment when they're behind the wheel. We also spend some time preparing them for that experience by describing the role of each party in the car. The occupational therapist will sit in the back seat and take copious notes about concerns that they view and strengths so that the positive feedback can be provided as well. The driving evaluator sits in the front seat, and this is an individual. We have a vehicle that is adapted just as you take in driver's education. So there's a brake on the passenger side as well. So the individual in the front seat with the client will give instructions on where to turn and, for example, instructions on appropriate stopping distances and so on. And then we review, of course, that the individual behind the wheel is in charge of all components related to driving and should do their best performance, but we will be giving them feedback on methods that they can do to improve their skills. So that's a summary of the inpatient component, or in-clinic component. Then we go out behind the wheel for about 45 minutes to evaluate the mechanical operation of the vehicle on the roadway. Oh, I should have moved on to this slide. My apologies, folks. I'm going to skip over that one. And here we are. So during the road test, it's what's your judgment like when a emergency vehicle approaches? How are you handling the pedestrian on the street who's taking a walk with their dog? Do you give them a wide enough berth? Do you have appropriate spatial planning there? Are you slowing down? Are you taking the correct path when you're turning onto a 4-lane road off of another 4-lane road? How are you doing interpreting your signs? Do you start a braking pattern that's appropriate before you reach an intersection and so on? I have a document in here that will show you the checklist that we use while we're in this experience. After the on-the-road part is completed, the results from the in-clinic and the behind-the-wheel are combined. For RHI, the clinicians who were participating in the car spend a few minutes just reviewing their notes and making sure that all components have been accounted for. The person who rides in the front seat very seldom takes notes, of course, for safety reasons. Recommendations are discussed between the two parties, and then the client and hopefully a family member will be drawn into the room to have a discussion about all the strengths and positive things in the driving performance, and then if there were any concerns in the driving performance. In addition, if adaptive equipment is recommended, excuse me, they will have had a chance to trial that while in the vehicle. And I know that later in our slides we give examples of those, but one might be a spinner knob so that someone has better control in tight turns. Another example is using a left foot accelerator if we have someone who's hemiparetic and they cannot use their right foot or leg anymore. Then they can accelerate the car with the left foot and then brake as well with the left foot. There's a variety of adaptive devices available. These tend to be the more common ones. So we will also discuss with them whether or not, after this experience, they should have lessons. Now, lessons can be recommended for a variety of reasons. Someone might have some visual spatial problems and they need to practice their positioning within a lane. Lessons might be recommended because they need to get more proficient at the equipment that they've just been introduced to. Someone might need lessons because they're having difficulties with their attention and concentration, staying really focused on all the components of the driving experience. At the end of this discussion, there is a written document that the person and the family member leave the room with that clearly explains the recommendations. This document will also go to the physician, and we have said to our clients that if they are cleared to return to independent driving and lessons are not recommended, they must have a physician's signature on the document that we provide them. We fax it to the physician usually the same day, but we also give a copy to the client and indicate to them that if they can get into the physician's office sooner than what we might have a fax turnaround, that would be an advisable way to manage it before getting behind the wheel again. We strongly indicate no driving until there's a physician's sign-off on the process. This slide actually shows a few other examples of equipment for the car. Again, too, that we do have the capacity to work with individuals who are in wheelchairs, and they might need lifts for entering or exiting the vehicle as well. We do have hand controls in our van. That is something that's listed on this slide that I didn't mention before. Wendy found some of these legal considerations on the Brain Injury Association of America's website. It's pretty consistent across the country that the person needs a valid driver's license. In some states, you have to present a copy of your driving evaluation to the Bureau of Motor Vehicles before resuming legal driving. It's also advisable to have your person check their state regulations related to returning to driving. And we often, after they go through our driving evaluation experience, recommend that the individual keep some extra copies, either in their vehicle or at their home, of the recommendations. We've had some situations where we've had individuals who are language impaired, maybe aphasic. I had a gentleman who had an acquired stutter after an acquired brain injury, and he had coordination and balance problems. And it was not uncommon for police officials to, if he did have difficulties driving, if he was pulled over, it was not uncommon for them to assume that maybe he was intoxicated because of his physical and speech difficulties. So having documentation is helpful. We also like to suggest to people that they're in contact with their insurance companies, their automobile insurance, because there may be some liability limits or certain requirements. If certain requirements are not met following a vehicular crash involving an injury. So we advise folks to be in contact with their insurance and make sure that they understand what the expectations are. As part of our system, we do think it's important to counsel individuals if they're not able to return to independent driving, and discuss with family and reassure individuals, as Wendy was pointing out, it's a very strong element of a sense of independence and quality of life and a feeling of control. So it can be extremely frightening, frustrating, aggravating when the recommendation is to retire from driving. So we like to provide options, education, and maybe even support. And we can help you fill out your application for Indigo, for example. We would be happy to help you contact SECOA and explore your region of the state and see what alternative transportations are available. It's, again, just part of that offering a service to a client so that instead of taking away opportunities, we offer some options. From this point, we're going to move into the case study, and here's where I'll turn it over to Susie Crane. She's going to talk specifically about a client where she was the resource facilitator who played a critical role in working with the VRBI specialist and orchestrating getting someone to return to driving.
Good afternoon. As Laura said, I'm Susie Crane, and I'm the resource facilitator. This particular gentleman, it's been a few years, so I had to refresh my memory on a lot of it. As you can see, he had a team, the vocational rehabilitation counselor, myself, and then he had support from family, which is often helpful in any recovery with a brain injury. Jack was 42, and you can see his injuries there. As a result, he wasn't able to drive. He did suffer some seizures after his acquired brain injury. He had the neuropsychological reevaluation done May of 2010. It showed that he had significant impairment in attention and auditory verbal memory. I think Laura could probably tell us more of what that would entail as far as how that would be significant in driving. For the attention, that's pretty obvious.
I think, as far as, maybe I'll just explain that second bullet, that the auditory verbal memory he had difficulties taking in what he was told because of his impairment in attention, so he wasn't able to retain the information. Now, I would assume that if he's driving somewhere and he has someone who's trying to describe to him a particular route, he's going to have a great deal of difficulty dividing his attention, absorbing what they're trying to explain to him, and performing the task in a safe manner.
As you can see, then he had average visual construction, which the visual spatial skills and average visual perceptual skills, impaired visual attention to the left. This would be a lot of difficulty with anything on his left, so that would create a problem when you're out in the car. The rest of the results from his neuropsychological reevaluation, he did have some weakness on the left. The arm and hand and the foot was affected. The left visual field deficits, as we mentioned, left neglect, and intermittent double vision. His executive thinking and planning was impaired, so this is definitely a problem when you're out on the road, because we know that it requires, as Wendy had mentioned, all the multitasking, and then your executive thinking would be very important with being on the road with everything that's going on. He had some problems with the mental flexibility. It had improved after his reevaluation from the first time that he was evaluated, and he had some. It was noted that he had significant depression the first time, and that had improved. So those would all overall be helpful in getting him to return to driving. His goals were to return to work, and in order to be able to do that, he needed to be able to drive. He had support from family, but his wife worked full-time, and so it was not possible for her to take him to work. And he did have a daughter, but she was too young to drive at the time. So it was very important to him to get back to driving. He needed to first work on trying to get some strength in that left arm, which he didn't, unfortunately didn't gain back a lot of the strength. He still had a lot of that weakness in the left arm and leg. He did go through physical or occupational therapy to work on those things and got some of that strength back, but not to the normal level. As I mentioned, he did have some seizures that he had to be cleared from with the doctor. And in order to be able to get back up to being ready to go back to driving, it was recommended that he participate in a 2-day program. So he did our program there at the Neuro Rehab Center. He participated in occupational therapy, physical therapy, speech, and vision. He, as I mentioned, he was not able to drive until he was released and cleared by his physician because of the seizures. So that was a part of postponing his return to driving. He came to resource facilitation in July of 2010. You can see his medications, and his goals, as I said, was to return to work. The assessment was done at that time, and that was one of the goals that I helped Jack work with, is to be able to work with a job coach and find work, and then also to be able to set up things for return to driving. He had a good job history, so his outcome of being able to find employment was good. The driving held him back on that. As I said, being able to get to and from work is very important. He lived, I didn't mention either, where he lived there was not public transportation, so he didn't have a bus system to be able to use that, so that's even more important to be able to get back to independent driving. Some of his therapeutic activities, he worked in individual and group settings in the clinic and the community to help improve some of the skills with inattention, the problem solving and the memory, the visual and the physical, and the mood. As I recall, we did have a long period of time where the mood was a real problem, just mainly with initiation. So in order to get him to be initiated to do the things that he needed to do to improve himself, to be able to get back to where he needed to be, even to be able to drive, was an issue that we had to work through. August 2010, the driver's eval was authorized by Voc Rehab, and some modifications were made for left-sided motor difficulties. He did have the spinner knob. There was also a turn signal lever which was extended so that he could, it was first of all on, it was on the right so that he could use it, but they had to put, I'm sorry, let me get this straight in my mind. He had to have it on the right in order to use it, and it was also, I believe it's a longer lever than what a normal turn signal is, so it's easier to access. Sometimes when people have driven before, we're all creatures of habit, so to be able to get used to any changes of where things are, as Laura mentioned, with the left pedals, that's not natural to us. If you've driven for a long period of time and are used to using your right side for those things, I think that's one of the hardest things to overcome, is to retrain ourselves and being able to use those from the opposite side of what we're used to. Jack was able to pass the driver's eval in August of 2010 on the 24th, and it was recommended that he have lessons. It's pretty typical if you have any adaptive equipment. Actually, it's probably legally, it is required that you have lessons so that you can learn to use that adaptive equipment. As I just said, getting used to using things maybe opposite of what we were used to before, those types of things. So if you have to have any adaptive equipment, it will be necessary to have some lessons. And that's left up to the examiner as to how many and when that's considered complete. Jack did have an older vehicle that was about 10 years old, and in order to get that any adaptive equipment put on that, Voc Rehab required that be inspected, because it did have a lot of miles, and it's pretty expensive to have these adaptations done, so you don't want to put a lot of adaptive equipment on a vehicle that's not going to be in running condition for very long. That took a while for him to get that in and get that inspected and those types of things, and I helped get some of those things set up for him so that he could continue to keep things moving towards getting all of the adaptive equipment put on the vehicle. And finally, after all that, he decided that he was going to purchase a newer vehicle, so then we had to wait on that. He was able to purchase a vehicle, and so then things were ready to move forward. As I said, I had kept in touch with Jack to make sure that, after he purchased his vehicle, checked with him periodically. Took him a while to find what he wanted, so I checked with him periodically to make sure that things kept moving. And he, once he got his newer vehicle, then he got it in to be modified, and the modifications were made. As I said, he had a spinner knob and the signal adaptation. were, I believe, the only things that he had on his vehicle. In the summary of this, just to show that the efforts that, of all those that it takes to get everything coordinated, we had a great VRBI specialist on board, the support of his family, and once he got going, finally the support with the client. I was involved in that. We had the providers, the body shop, those types of people that had to be involved in getting all those things done. And of course, the funding source. That's very important to have a good VR system in place for that. He was able to, by the time that his case had closed, he was able to find employment, and he was able to drive back and forth to his job, which was very important to him. I know that at one point he had an offer for, or he had applied for a job, but it was a job where it required a company vehicle to do parts delivery. And unfortunately, they wouldn't let him drive his own vehicle with the adaptations on it because of legal insurance purposes, but he also was not allowed to drive theirs without the adaptations, so that was not a possibility for him as far as employment. I'm going to go back one slide.
I was just going to ask Susie, this is Laura. I was going to ask Susie to talk a little bit more about his return to work and what he's doing and how many hours a week he's currently working.
When he went back, it was just on a kind of a part-time basis. He was able to go back. He was doing sales at Walmart when he went back, and then he had worked up to full-time. I know with him, the independence of being able to drive was so important, not only for work, but as I said, he had a daughter, and she was young and couldn't drive, so in order to provide transportation for the things that she needed, with him working part-time, that made him the ideal candidate to be able to take his child back and forth to places that she needed to be, with his wife working full-time. And that was another goal for him to be able to drive, was, he wanted to be able to help out in the home since he wasn't working full-time at that point. And so that provided a lot less stress for the family, for him to be able to take his daughter and to do the things that they wanted to do when she was out of school, to be able to do things with her. So, very good. I think our last slide is the acknowledgments. So at this point, if anybody has any questions, we're open for questions. I haven't seen any come up on the screen, but I'm not sure how to. It's star 5. I think if we unmute you, you can be able to ask by phone, or you can type.
We're going to unmute the line now, and hopefully you'll be able to talk. Star 5.
I think that's
all callers are muted.
Whoops, hang on.
Whoops.
All callers are unmuted.
Okay, you're all unmuted now. Are there any questions people want to ask out loud, or if you'd like to type in any questions? So far, it looks quiet.
Oh, when Laura was talking about people going out during the driver's eval, something I wanted to ask, are family members allowed to go in the vehicle?
We do not have families go in the vehicle, and I think that there's probably a couple of reasons for that. First, we want the client to not have any additional distractions than they already have with 2 other members in the car. And we don't always know how a family member is going to respond to the driving situation. They might feel increased anxiety. They might try to jump in and participate in some way. It would just make the situation, I think, more difficult for all parties concerned. And then I believe that there might not be adequate liability coverage. That part I have not asked specifically to the gentleman that assists us in our driving evaluations, but I think that is a component as well.
This is Wendy. I just wanted to make one more point. A lot of times, again, we talked about driving being your independence, being your sense of control, community reintegration, and it may be very difficult for family members to have this conversation with their loved one about why they can't drive and have to hide those car keys, because I know that that has to happen quite often. So sometimes it is best to seek out a neuropsychologist or a driving evaluation program so that the family member is not the one giving the bad news. It's a professional that doesn't live with the person and spend, much time with them. So that's another reason that I've heard family members have to have a difficult conversation with their loved one. And a lot of times if you have a professional have that difficult conversation, it might go over a little smoother. And again, you may not have to deal with any consequences after you have that difficult conversation. I see that one person has raised their hand. Roger, did you have a question? Another thing, one of the handouts, it did say that you can get the listing of all of the eligible. Oh, thank you, Roger. He said no, he doesn't have a question, but great point. And trust me, I have had working with families for 9 years. I've had plenty have to hide those car keys, and sometimes the clients have found them, or even have to park the car somewhere else. I've had that as well, because it's a huge, huge point of independence. And a lot of times when people are first becoming aware after they have a brain injury in the hospital, they still don't understand why they're not able to drive. Obviously, they've had a brain injury and they're a little bit confused. If you need a listing of the certified driver rehabilitation specialist in the state, you can go to the website listed before, or if you'd like to, you can type your email in, and I'd be happy to email you the handout if you did not get it already. Again, I think the website was www.aded.com, I'm guessing. I don't know. No, www.driver-ed.org. And I do have an up-to-date listing of all of the specialists. I'd be happy to email it to you if you type your email in.
It does not appear that we have any additional questions right now. Oh,
Maybe they're typing.
I'm sorry, I spoke too soon. We have some individuals typing. We don't know yet what the messages are.
While we're waiting, I don't know if I'll put Laura on the spot, but I've had several clients here recently that did not have a driver's license before their injury, so I don't know if she can kind of go over the process of what that would include if they had never obtained a driver's license.
I would have to explain a little caveat. I've done driving evaluations for a while. I'm not currently doing them within the RHI system. Sometimes the procedures and the standards and the laws do change. From what I know, I can pretty carefully, comfortably say that Crossroads is comfortable taking drivers that have not, brand new drivers. I can tell you that the Rehabilitation Hospital of Indiana has had one or two. That's an area that we're just beginning to branch into. There is quite an extensive process of working with the individual to make sure that they get enough hours behind the wheel with the appropriate modifications, with the appropriate staff members in the car, and then sometimes they're able to, they as in the team of professionals, are able to turn over some of the hours to the family members for finishing it off if they feel that the client is proficient enough with utilizing all the different pieces of equipment. Last time I looked into this, I believe it's a 50-hour a week, but some other individuals on the line might know the number of hours that are required. I've never personally worked with a brand new driver, but I think that they have to have 50 hours behind the wheel. So, for example, maybe their rehabilitation team can get them to 30 hours and they're very proficient, they're very comfortable, and they know how to use the equipment. Then it's possible if the professional team interacts with the Bureau of Motor Vehicles to make sure it's an acceptable transition, they will transfer the knowledge over to the family and have the family finish off the remaining number of required hours behind the wheel, and then the person would go to the Bureau and obtain their amended license that says equipment is required and so on. It looks like a lot of people are writing in for their website, so we're still collecting names and email addresses for people who want the ADED website. Did I answer your question?
Mm-hmm. Yeah, I thought that might be a point to bring out.
Alice Reichard has added, thank you, Alice. VR has an approved list of driving evaluators and trainers. I'm guessing it's not as long as everyone that is certified in the state. It may be that you can all see each other's writing. That I'm not familiar with either.
There's 23 different programs and people listed on the list. I'm going to email you all out, and I am writing down all of your emails. But try to remember what Laura mentioned earlier in the webinar, that usually what is recommended for someone with a brain injury is a CDRS. So when I send you this listing, look after their names, and you'll see different initials on after them. One might say OTR, which means occupational therapist registered, or it might say CDRS, which is certified driving rehab specialist, or there's different kinds of initials after people's names, or there may be no initials after their names. So take that into consideration when you're looking at the list, that usually the CDRS is what's recommended.
You know, I'd like to add in addition to that one CDRS does not necessarily feel comfortable managing all sorts of different client needs. Within our system, for example, we have a CDRS who is very comfortable interacting with the spinal cord injury clientele, and we may have another CDRS, for example, who would be more comfortable working with someone with visual perceptual difficulties, cognitive impairment, and so on. So you might advise your clients when you are exploring or they're exploring which path to take, to raise questions about even subspecialties within the CDRS.
I think if no one has any more questions, we're going to leave the webinar on so that we can keep collecting people's emails and information. If you have any additional questions, you're welcome to type them there. But we're going to go ahead and end the webinar. We're going to leave it up so you can type stuff in, but if no one else has anything to say, we thank you for joining us and for listening to us and for being a part of this, and we thank you for all you do every day. Have a good one. Be safe out there. Bye-bye.